Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Thank you for joining us for this clinical clip titled Emerging Evidence in Myasthenia Gravis, Key Updates from the American Academy 2025 Annual Conference. My name is Dr. Nick Silvestri, and I'm a professor of neurology and associate dean for student academic affairs in the Department of Neurology at the Jacobs School of Medicine and Biomedical Sciences. In this clip, I'll highlight key data presented at the conference in San Diego, California this past week. The first abstract that I'd like to discuss is Phase 3 inebilizumab trial, the MINT trial, and this was presented by Dr. Richard Nowak from Yale, and this focused on efficacy and safety results in patients with generalized myasthenia gravis. So that was the objective of the study, and just as a background, we know that autoreactive B cells are pivotal in the upstream pathogenesis of generalized myasthenia gravis. So this trial was designed to look at inebilizumab, which is a CD19 inhibitor, in the treatment of patients with generalized myasthenia gravis. So the MINT trial was a Phase 3 clinical study that was conducted in adult patients with GMG, and it included a protocol-required steroid taper. So this is a very novel aspect of this trial. And the complete randomized control panel was a 52-week trial in the acetylcholine receptor population and 26 weeks in the MuSK population. Participants were randomized 1:1 to 300 milligrams of intravenous inebilizumab or placebo, and it was administered on day 1 and day 15, and at week 26 in the acetylcholine receptor population only. The primary endpoint in this trial was a change in baseline MG-ADL score at week 26 in the combined population. So a total of 238 patients were randomized to either inebilizumab or placebo, and the primary endpoint was achieved demonstrating a clinically meaningful improvement in the MG-ADL score in the inebilizumab group, so minus 4.2 points as compared to placebo, 2.2 points at week 26. The key secondary endpoints were also all in favor of inebilizumab over placebo. Adverse events occurred in 80.7% of inebilizumab-treated patients and 73.1% of placebo-treated patients, with serious adverse events occurring in 8.4% of the treated group and 13.4% of the placebo-treated group. So in conclusion, this study provided evidence that inebilizumab is effective and safe for patients with both acetylcholine receptor positive and MuSK positive generalized myasthenia gravis, again, giving evidence that targeting an upstream mechanism such as B cells using a CD19 inhibitor can be effective and reduce the steroid burden in patients with generalized myasthenia gravis. The next abstract I'd like to discuss is fixed cycle and every other week dosing of intravenous efgartigimod for the generalized myasthenia gravis, and this is part B of the ADAPT-NEXT study. This was presented by Dr. Kelly Gwathmey from VCU and her colleagues. So the this is a Phase 3B ADAPT-NEXT study. This was looked at to investigate the safety and efficacy as well as tolerability of giving efgartigimod every other week or in fixed cycle dosing regimens. So we know that efgartigimod was approved back a few years ago to treat adult patients with generalized myasthenia gravis with acetylcholine receptor positive antibodies. But in the past, this medication has been given with cyclical dosing, so typically 4 weeks on with a variable interval between fixed other doses or other cycles. So this trial really looked at a way to see if every other week dosing on a more of a fixed schedule would be just as beneficial. So this study included adult patients with AChR positive generalized myasthenia gravis, and they were randomized 3:1 to either Q2 week dosing or fixed cycle dosing with 4 weekly infusions, 4 weeks between cycles. In part B of this trial, participants in the fixed cycle arm received 1 additional cycle of 4 once-weekly infusions of efgartigimod before switching to a Q2 regimen. And all participants had the option to switch to every 3 weeks in part B, depending on a clinical assessment. So 69 participants were treated in part A, and what the study basically showed is that in the fixed cycle arm versus the Q2 arm, there were really no changes in terms of the magnitude of MG-ADL drops. So to say it another way, both study arms actually showed improvement. So whether it was given in cyclical dosing or 2-week dosing. So this trial demonstrated that building on previous studies provides additional evidence for efgartigimod dosing approaches, so whether it's fixed cycles or Q2 week dosing, to maintain clinical efficacy in patients with GMG. In other words, it appears that Q2 week dosing is just as effective if efgartigimod is given in cyclical dosing. The next abstract I'd like to discuss is the effect of rozanolixizumab on ocular symptoms in patients with GMG. So this was a post hoc item level analysis of the myasthenia gravis specific outcomes in the Myasthenia trial, which was the phase 3 trial of rozanolixizumab in adult patients with generalized myasthenia gravis. So the objective here was to investigate the effect of rozanolixizumab on ocular symptoms in patients with GMG. And so the background here really is that we all know that ocular symptoms could be quite debilitating to patients, whether we're talking about ptosis or diplopia, and can be very difficult to treat. And so, if you recall, in Myasthenia, rozanolixizumab demonstrated clinically meaningful improvements across myasthenia gravis specific domains and was well tolerated. So this was a descriptive post hoc analysis evaluating the mean change from baseline in ocular item scores in the MG-ADL. QMG and MG symptoms patient reported outcomes, MG symptoms pro, and ocular muscle weakness scales for patients in the baseline who had a baseline of 1 or greater in that item as well were assessed. So overall, 200 patients received rozanolixizumab throughout the course of the trial or placebo, and the main baseline scores for ocular items were 1.6 to 1.9 for MG-ADL, 1.8 to 2.1 for QMG, and 1.5 to 1.8 for MG symptoms pro. For the rozanolixizumab groups, ocular items scores decreased 0.6, 0.6 in both treated groups versus 0.2 respectively for double vision, and 0.5, 0.7, and 0 improvements in terms of the scores for ptosis. So in other words, there were benefits seen in the ptosis scores in patients treated with rozanolixizumab versus no change in those treated with placebo. The mean change from baseline in clinician-assessed QMG scores was 0.6 and 0.8 and 0.1 respectively for double vision, again, all favoring rozanolixizumab versus placebo, and 0.5, 1, and 0.5 respectively for ptosis, generally in favor of treatment with rozanolixizumab. Similar improvements were seen in the MG symptoms pro, and most treatment emergent adverse events with rozanolixizumab were mild to moderate in severity. So in conclusion, overall greater improvements in ocular item scores across MG-specific outcomes were observed with rozanolixizumab compared to placebo in the Myasthenia trial, suggesting a benefit for patients with generalized myasthenia gravis in terms of their ocular symptoms. So again, very important for our patients given the burden of ocular symptoms on their quality of life. The next abstract I'd like to discuss is neurologists' therapeutic inertia in the management of generalized myasthenia gravis. And so the aim of this study was to assess, again, therapeutic inertia in patients with GMG, therapeutic inertia being a lack of willingness or a lack of thinking to change medications when patients report or doctors feel that they're doing good enough. So limited information is available on how neurologists make therapeutic decisions in GMG, especially now that new treatments with different mechanisms of action, administration, and safety profiles are approved. So this was an online cross-sectional study conducted in collaboration with the Spanish Society of Neurology in 2024. Neurologists answered a survey of demographic characteristics, professional background, behavioral traits, and then did simulated case scenarios. A therapeutic inertia score was defined as the number of simulated case scenarios that resulted in a lack of initiation or in some cases intensification to more efficacious treatments when the therapeutic treatment goals were unmet. And that's meant an increase in MG-ADL scores by at least 1 point. The scenarios included 4 treated class 2A or 2B patients with limb or bulbar symptom worsening, 1 treatment naive patient, 1 rapidly progressing patient, and 1 with ocular symptom worsening. And then they looked at the relationship between therapeutic inertia presence and neurologist characteristic success through chi-square and Mann-Whitney U tests. So a total of 149 neurologists were included. The median number of GMG patients that each of these physicians saw was 10, with a range of 5 to 20. And a proportion of about 35% of participants reported using minimum symptom expression, which is defined as an MG-ADL score of 0 or 1, to guide treatment decisions. Overall, about 80% of participants presented with therapeutic inertia in at least 2 out of 7 scenarios, and the mean therapeutic inertia score was 3.7. There was a lower perceived ease of use of the new targeted treatments, low organizational support for the introduction of these new therapies, and a higher overall resistance to change in behavior and related to therapeutic inertia presence. So this is very important because it outlines that therapeutic inertia is common in those of us who treat patients with generalized myasthenia gravis. And I think we really need, especially in light of all of the therapeutic advances we've had in the field of GMG over the past several years, to reassess whether our patients are doing good enough or if we could be doing better, perhaps with using newer targeted therapies. The next abstract I'd like to discuss is one that I was actually involved with, but Dr. Kavita Grover is the lead author. This is real-world treatment patterns among patients with generalized myasthenia gravis. And so the objective of this abstract was to evaluate real-world treatment patterns and myasthenia gravis-related clinical events among patients with GMG in the US. And so what we did here, we used the Komodo Research Database, and we looked at the baseline characteristics, demographic characteristics of patients diagnosed with GMG, as well as follow-up, which was defined as equal or greater to 12 months post-index for treatment patterns, including the 5 first observed treatment episodes. MG exacerbations and crises were also described. And so we found almost 6,200 patients. Among those receiving treatments from the first episode to the 5th episode, acetylcholinesterase inhibitor, so medicines like pyridostigmine use, declined from 81 to 58.5%. Corticosteroid use fluctuated between 48.2 and 63.2%, and the use of the following treatments increased. So non-steroidal immunosuppressants such as azathioprine or mycophenolate increased from 11.8 to 41.8%, immunoglobulins from 6.3 to 15.6%, FcRn inhibitors from 0.1 to 2.7%, and C5 inhibitors from 0.2 to 2.9%. The mean time from index date to FcRn initiation was 20.7 months, and to C5 inhibitor initiation was 15.8 months. And so what basically this data is showing is that over time, the treatment patterns are changing. So fewer patients on acetylcholinesterase inhibitors, corticosteroid use fluctuating, more patients on non-steroidal immunosuppressant drugs, slightly more patients on FcRn inhibitors and C5 inhibitors. But you can see by those overall percentages that the number of people, at least in this database review, on FcRn antagonists or on C5 inhibitors was fairly low. As I said, we also looked at crises and exacerbations. These were most common 1 year post-index, so 41.5%, and then declined over time so that by the time we saw the 4th year, it was 14.4%. And this is consistent with previous research that indicates that patients are most likely at crisis in the first 2 to 3 years after their diagnosis, with the likelihood of crisis decreasing over time. So in conclusion, conventional treatments and the initial treatment strategy for most patients in this cohort were used most frequently early on, as I mentioned, with targeted treatments used later in most patients that we saw. The next abstract I'd like to discuss is comparison of thymectomy outcomes between young and elderly myasthenic patients. This was reported by Drs. Morgan Haber and Yubing Lee from the Cleveland Clinic. And this was done to determine if thymectomy is equally efficacious in elderly patients described as 50 years or above. That's the conventional terminology used in myasthenia gravis: early onset before 50 years, later onset over 50 years. And so the idea here was we know from the MGTX trial that thymectomy is of benefit in the 50-year or less cohort. The question here is it in fact beneficial in patients older than 50 years as well? So this was a review of electronic medical records, which were retrospectively searched for non-thymomatous MG patients undergoing thymectomy between the years of 1999 and 2022, again at the Cleveland Clinic. And data including antibody status, Myasthenia Gravis Foundation of America classification prior to surgery, treatment at the time of surgery, clinical status, reduction in immunosuppression medications, MG exacerbations, and postoperative complications, or the development of cancer or autoimmune diseases was followed over time. And this study identified 79 patients that underwent thymectomy at that institution over the time that I mentioned. 45 of those patients were younger than 50 years, and 34 patients were over 50 years at the time of thymectomy. The median time of follow-up post-thymectomy was 6 years in patients below 50 years and 3.2 years in the group of 50 years or above. So between the two age groups post-thymectomy, there was no difference in the percentage of patients that improved in their MGFA classification. There was no difference in the degree of corticosteroid reduction, the timing of the earliest corticosteroid reduction, the reduction in the number of MG therapies or MG exacerbations or post-op complications, diagnosis of cancer, or development of other autoimmune diseases. The MG-ADL scores at the last visit for the 28 patients in the elderly group, with 15 of the 28 or over 50% achieving this minimal symptom expression. So to conclude, based on the results of this study, it seems that the efficacy and safety of thymectomy in elderly patients with non-thymomatous MG is similar to that of the younger counterparts, and these findings support the use of initial thymectomy in the management of patients with generalized myasthenia gravis who are 50 years or older. The final abstract I'd like to review is the effect of zilucoplan on myasthenia gravis specific outcome subdomains in RAISE, a phase 3 study of zilucoplan, again in the treatment of generalized myasthenia gravis. So in RAISE, zilucoplan demonstrated rapid and clinically meaningful improvements in MG-ADL and QMG total scores versus placebo in adults with acetylcholine receptor positive MG. And since myasthenia gravis affects a wide range of muscle groups, the analysis of efficacy within specific muscle groups will enhance the understanding of zilucoplan treatment in patients with GMG. So the objective of this study was to evaluate the effect of zilucoplan, which again is a macrocyclic peptide that blocks complement to C5 inhibitor on MG-ADL and QMG subdomain scores, including ocular, bulbar, respiratory, and limb and axial muscle groups in patients with GMG. So patients in RAISE, which again was a phase 3 multi-center double-blind placebo-controlled trial, were randomized to either self-administer injections on a daily basis of zilucoplan or placebo, and the primary endpoint was the change from baseline in MG-ADL total score at week 12, with exploratory analysis assessed and change from baseline in MG-ADL and QMG subdomain scores for patients with a baseline score of 1 or more in that specific subdomain. So what were the results? So at week 12, least squares mean change from baseline and MG-ADL total score with zilucoplan was minus 4.39, and for placebo was minus 2.3. And for the QMG score for zilucoplan was minus 6.19 for zilucoplan and minus 3.25 for placebo. In terms of subdomain scores, the bottom line here is that in all subdomain scores, there was a benefit of zilucoplan over placebo. And this includes ocular subdomains, bulbar subdomains, respiratory subdomains, and limb and axial subdomains. Improvements in subdomains were also seen in all of these categories in the QMG as well. So in conclusion, for this abstract, zilucoplan treatment led to improvements relative placebo across all subdomain scores in MG-ADL and QMG as compared with placebo. So thank you again for joining us for this clinical clip entitled Emerging Evidence in Myasthenia Gravis, Key Updates from AAN 2025. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit and access downloadable slides. Thank you very much.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.